Assalamu alaikum doctors. In this video I am discussing about the epilepsy syndrome. So epilepsy syndrome, it comes history, it comes on the video station frequently coming, and also epilepsy come on communication counseling like advice. What are the advice you give in epilepsy syndrome patient? There is a seizure with developmental delay. Differential diagnosis we can choose Leschner-Hans syndrome, Lennox-Gastaut syndrome, and Landau-Klafter syndrome, West syndrome. So what history would like to ask in epilepsy syndrome patient? These are the onset, course and duration, what make it better and what make it worse. Is it first time or recurrent occur? Is there any video recording available or not? What happens before or during or after? Loss of any consciousness, eye blinking, staring, ruling up, apnea, tachycardia and cyanosis. Any skin stigmata, sign of increased intracranial pressure. Perinatal history, natal history, fast cry, resuscitations, postnatal history, any fever and trauma, any family history of epilepsy, sudden infant death, developmental history, school performance and vaccination, drugs. So these are the history we like to ask. Then what do you want to examine? A, B, C. Airway, breathing and circulation, Glasgow Coma Scale. Vitals, I will check the heart rate, blood pressure and respiratory rate, oxygen saturation, hydration status and entry forternally. Full neurological examination and cranial nerve examinations. Assess his visions and hearing, development, head size and shunt, neurocutaneous stigmata. How will you manage him? So management including random blood sugar, I will do the blood pressure, serum electrolyte, calcium and magnesium, ABG, full blood count, coagulation, serum ammonia, amino acid, metabolic screening and urine toxicology. Drug level, EEG if normal, do with sleep or with sleep deprivation. Brain imaging, MRI brain and CT. Multidisciplinary team I will involve my consultant, neurologist, epilepsy nurse, genetics if syndrome and counseling development lies with the school, occupational therapy for home modification and educational health plan. So important management of the epilepsy status epilepticus patient. At the 0 minutes, I will do the AVC, I will do the RVS, I will confirm that it is an epileptic seizure and I will give the high flow oxygen and check the blood glucose level. Then at the 5 minutes, midazolam. If IV access established, then lorazepam 100 microgram per kg, maximum 4 milligram. Midazolam may be given by parents, carers or ambulance crew in the non-hospital setting. So if non-hospital setting we are giving midazolam, if IV access possible, first dose of lorazepam we give. Then 15 minutes give the second dose of lorazepam or first dose if midazolam has already been given. To take place in hospital setting, call for senior help, start to prepare for phenytoin and reconfirm it is an epileptic seizure. Then at the 25 minutes, I give the phenytoin 20 mg per kg IV irritant to the veins and see below over 20 minutes, or if on regular phenytoin, phenobarbital 20 mg per kg IV over 5 to 10 minutes. Paraldehyde 0.8 ml per kg of mixture 50 in 50 diluted in olive oil may be given as enema. Seek senior advice, inform PIQ staff or senior anesthetist. Then 45 minutes repeat sequence induction of anesthesia using thiopentol sodium 4 mg per kg IV and transfer to the PIQ phenytoin IV. In epilepsy patient, when the indications for EEG. So indications for EEG, number 1, it is clinically diagnosed epilepsy. Number 2, after an episodic of status epilepticus. Number 3, unexplained coma or encephalopathy. Number 4, suspicion of non-convulsive status in children with learning difficulties and epilepsy. Number 5, acquired regression of speech or language function. Number 6, developmental regression suspected to have neurodegenerative conditions. Number 7, to monitor the progress in West syndrome and non-convulsive status. Now EEG not indicated. When we will not do the EEG? If it is a funny turns, apneic attack, disease spells, strange behavior. So if it is a serious seizure, we will not do EEG. Number 2, non-convulsive episodes. Example, syncope, reflex anoxic seizure, breath holding episodes, EEG more appropriate. Number 3, febrile seizure. Number 4, single uncomplicated generalized tonic-clonic seizure. Number 5, to monitor the progress in well-controlled epilepsy. And number 6, before stopping the treatment. Indication for MRI of the brain when we do focal epilepsy. Number 1, focal epilepsy including the TLE except the Ronaldic seizure. Number 2, epilepsy in children age less than 2 years, MRI of the brain we are doing. Less than 2 years, lots of disease can be. Number 3, myoclonic epilepsy. Number 4, intractable seizure. Number 5, loss of previous good control. Number 6, seizure continuing in spite of first line medication. Number 7, associated neurological deficit or appearance of new neurological signs. Number 8, developmental regression in children with epilepsy. Number 9, infantile spasms, West syndrome. What are the indication of drug level in epilepsy? Baseline suspected non-compliance, organ failure, need ICU admission before changing dose, indication of antiepileptic drug in fast attack, neurological deficit CP, abnormal EEG and parental request. Withdrawal a drug. When seizure free for 2 years, discuss risk of recurrence, postpone if important events coming. How? Gradual withdrawal over 2 to 3 minutes, phenobarbital over 6 to 12 minutes. Recommends treatment if recurrent 25%. So this is all about epilepsy, which is very important in exam. Thank you very much.